Doctors, can you see the PowerPoint?
Yes po, Doc.
Yung mga non-master slide, ang presenter view.
Opo.
Okay. So, 97 pala tayo nga din yan, ha? Sige, let's wait na lang until 1:10, then I'll start na. Good afternoon, doctors. So before we start with our lecture for this afternoon, can I ask someone to please lead the prayer first?
Ako na lang po, Doc.
Sige po, Doc.
In the name of the Father, and of the Son, and of the Holy Spirit. Amen. Dear God, we thank you for this day. We pray that you bless us with your loving hands as we listen to Dr. Isaiah's lecture, and may you guide us in taking our first bi-monthly exam in PCM later after Pharma. Our Father who art in heaven, hallowed be thy name. Thy kingdom come, thy will be done on earth as it is in heaven.
Bless this day our daily bread, and forgive us our trespasses as we forgive those who trespass against us. And lead us not into temptation, but deliver us from evil.
In the name of the Father, and of the Son, and of the Holy Spirit. Amen.
Okay, so good luck sa exam ngayon niyan.
Thank you, Doc.
Kumusta ngayon ang exam niyo ng micro? Nakulan ka muna ako ng exam. Anyway, sige, let's start with our lecture. So for this afternoon, we are going to talk about chapter 16 of your book, which is Histamine, Serotonin, and the Ergot Alkaloids. So even before the name histamine, serotonin was discovered, it has long been known by people na there is something in the tissue. There's a substance in the tissue in which when there is a stimuli like trauma, ganon, there will be physiologic effects like reddening of the skin, pain or itching, and in the lungs, bronchospasm. So it was then discovered that these substances was also present in the nervous tissue, such as in the brain and in the spinal cord, and they have multiple functions. Okay, so histamine and serotonin. So serotonin is also known as 5-hydroxytryptamine or 5-HT for short. So they are biologically active amines that function as neurotransmitters, and these are the ones na was discovered that produces a physiologic effect in tissues. So in the neural tissues, so they have complex physiologic and pathologic effects through multiple receptor subtypes because there are different receptors that wherein this histamine and serotonin binds. And for each receptor, there is an effect. So together with endogenous peptides, prostaglandins, and leukotrienes and cytokines, they constitute the otacoid group of drugs. So when we talk about otacoid, so they act like hormones, and they have a brief duration wherein they also their effect is primarily local. So it is for example, it is synthesized in one site. They act near that site only. However, if there is large quantities of the otacoid group of drugs, then they can move into circulation. So because of their broad and largely undesirable effects, peripheral effects, neither histamine nor serotonin has any clinical application in the treatment of disease. So, however, compounds that selectively activate certain receptor subtypes or selectively antagonize the actions of these amines are of considerable clinical value. So we don't use histamine nor serotonin clinically. We only use the agonists and the antagonists of these amines. So we are going to talk about histamine. So its basic pharmacology, clinical pharmacology, the antagonists, and the basic pharmacology of each one receptor antagonists. So histamine occurs in plants as well as in animal tissues, and it is a component of some venoms and stinging secretions. So in other words, the bees, and as well in other venomous animals like snakes. So histamine is formed by the decarboxylation of the amino acid L-histidine through the histidine decarboxylase enzyme. And the reaction catalyzed in mammalian tissues, this is the histidine decarboxylase. So once formed, histamine is either stored or rapidly inactivated. So most tissue histamine is sequestered and bound in granules or vesicles in mast cells or basophils, wherein the histamine content of many tissues is directly related to their mast cell content. So mast cells are especially rich at sites of the potential tissue injury, like in the nose, mouth, and feet, the internal body surfaces, and blood vessels, particularly at pressure points and bifurcations. We also have mast cells that are, histamine that are not found in the mast cells. So they are found in several tissues, which includes the brain, wherein in the brain it functions as a neurotransmitter. So the bound form of histamine is biologically inactive, but many stimuli can trigger the release of mast cell histamine, allowing the free amine to exert its action on surrounding tissues. So very little histamine is excreted unchanged, since a histamine is being converted to these three molecules: the N-methylhistamine, methyl acetic acid, imidazole acetic acid, and imidazole acetic acid. Sorry. So going back to our non-mast cell histamine, strong evidence implicates endogenous neurotransmitter histamine in many brain functions. So they function for neuroendocrine control, cardiovascular regulation, thermal and body weight regulation, and sleep and arousal. A second important non-neuronal site of histamine storage and release is the enterochromaffin cell in the fundus of the stomach. So the enterochromaffin-like cells release histamine, which is one of the primary gastric acid secretagogues, to activate the acid-producing parietal cells of the mucosa. So histamine helps in the production of the hydrochloric acid in the stomach. So the stores of histamine in mast cells can be released through several mechanisms. So our first mechanism is through immunologic release. So immunologic process account for the most important pathophysiologic mechanism of mast cells and basophil histamine release. So these cells, if sensitized by IgE antibodies attached to their surface membranes, they granulate explosively when exposed to the appropriate antigen. So by a negative feedback control mechanism mediated by H2 receptors, histamine appears to modulate its own release and that of other mediators from sensitized mast cells in some tissues. In humans, mast cells in skin and basophils shows this negative feedback mechanism. Lung mast cells do not. So in other words, this histamine is important in the, what do you call this? In the type 1 hypersensitivity reaction. But before that, there's always a sensitization phase, as you can see in the slide. It needs to be sensitized first before taking effect on the second wave. So, but before we have type 4 four types of hypersensitivity. So for the type 1, histamine is the main player for the reaction. Okay. So endogenous histamine has a modulating role in a variety of inflammatory and immune responses. So upon injury to a tissue, the released histamine will cause the local vasodilation and leakage of plasma-containing mediators of acute inflammation. So the mediators of acute inflammation includes the complement, the C-reactive proteins, as well as the antibodies. So histamine has an active chemotactic attractions for inflammatory cells as well. So the inflammatory cells, this includes the white blood cells, neutrophils, eosinophils, basophils, monocytes, and lymphocytes. So histamine inhibits the release of lysosome contents and several T and B lymphocyte function. So most of this is mediated by H2 or H4 receptors. And the release of peptides from nerves in response to inflammation is also probably modulated by histamine acting on presynaptic H3 receptors. But basically, H2 or H4 receptors are the ones in play in the inflammatory response. H4, wherein it causes the mast cell degranulation. So another process for storage and release of histamine is through chemical and mechanical release. So there are certain amines like morphine and tubucurarin can displace histamine from its bound form within cells. So this type of release does not require energy. Oh, by the way, kanina, the immunologic release requires energy as well as calcium, while the chemical and mechanical release does not. And is not associated with muscle injury or explosive degranulation. So loss of granules from the mast cells also release histamine because sodium ions in the extracellular fluid rapidly displace the amine from the complex. So chemical and mechanical muscle injury causes degranulation and histamine release. So we have this compound 48/80, which is an experimental drug, and it selectively releases histamine from tissue mast cells by an exocytotic degranulation process, which requires energy and calcium. Although it requires energy and calcium, it doesn't mean that this is part of the immunologic process, since, of course, we are using a drug to trigger the release of the histamine. So histamine exerts its biologic actions by combining with specific receptors located in the cell membrane. So there are 4 different histamine receptors that have been characterized and are designated as H1, H2, H3, and H4s. Okay, so all 4 receptor types have been cloned and belong to the large superfamily of G protein-coupled receptors. So as you can see here in table 16-1, we have the histamine receptor subtypes and their distribution. For H1, we have it in the smooth muscle in the endothelium and brain. For H2, we have gastric mucosa, cardiac muscle, mast cells, and brain, and so on and so forth. So what we really need to know here is the post-receptor mechanism of each of the receptor subtype, because there is a different alpha subunit that is being released for each different receptor subtype, because histamine receptors are G protein coupled receptors. In other words, the G protein, when the receptor is being activated, the G protein will be its subunits, the alpha and the beta subunits, will be dissociated and will be released. And the release of this alpha subunit will now trigger another messenger. So here we can see the GQ, GSGI. So these are alpha subunits. They are not the G protein itself, but is the type of alpha subunit of the G protein. So GQ is the alpha subunit of the G protein for Q, and so on and so forth. So for GQ, it triggers the increase of the IP3 and the DAG, the diacylglycerol, as well as the inositol triphosphate. And for the GS, it increases the cyclic adenosine monophosphate, or the CAMP. While for the GI, since kaya sinabing I because it is inhibitory, so it decreases the CAMP molecules. Okay. So the structures of the H1 and H2 receptors differ significantly and appear to be more closely related to muscarinic and 5-HT1 receptors respectively than to each other. The H4 receptors has about 40% homology with the H3 receptor. They are somewhat the same, but they are not closely related with the H1 and the H2 receptor. So all four histamine receptors have been shown to have constitutive activity in some systems. Thus, some antihistamines previously considered to be traditional pharmacologic antagonists must now be considered to be inverse agonists. So indeed, many first and second generation H1 blockers function as inverse agonists. So what is the difference between an inverse agonist from an antagonist? Anyone? Baka the same lang na tira effect. Pero how do they differ?
Receptor, Doc.
Kaya ano receptor? Hinato. Ay, Dr. Abrehas.
Inverse agonist binds to the same receptor as agonist. Tapos antagonist binds to different receptors. Diba?
Na pakiutro daw, wala ko makaintindi. Sorry.
An inverse agonist, they bind to same receptors pero different niya effect. Tapos an antagonist is iba talaga niya effect ngatuhan different receptor.
May pagkaharani na an inverse agonist, the effect is an opposite, baka it counteracts. An antagonist, it blocks the production of the effect supposedly, and if it is not blocked, na gets?
Yes, Doc.
Bagan, if we're talking about inverse agonist, pag an inverse agonist magbind niya sa receptor, it may na po bagan supposedly let's say for example an supposedly ginihimo han histamine, pag magbind nato nga receptor mag-vasodilate, pag mag-attach ang inverse agonist, it will vasoconstrict. Amon i-effect ang inverse agonist. An antagonist, for example, magbabasodilate supposedly pag ang histamine ang magbind. An antagonist, mabind hiya nga to in order for para diri na makagbind ng histamine. Therefore, diri mahinabo ang vasodilation. Naintindihan? Okay na?
Yes, Doc.
Yes,
Okay.
Doc.
Okay, sige. Anyway, hinabakitad pa. Okay. So, yun nga. So, many first and second generation H1 blockers, H1 receptor blockers function as inverse agonists, so not antagonists. So, furthermore, a single molecule may be an agonist at one histamine receptor and antagonist or inverse agonist at another. For example, we have clovin propyl, which is an agonist at H4 receptor, but is an antagonist or inverse agonist at H3 receptor. So in the brain, H1 and H2 receptors are located primarily on postsynaptic membranes, whereas H3 is predominantly presynaptic. Histamine is a powerful stimulant. This is for the tissue and organ system effects, by the way. For the nervous system, histamine is a powerful stimulant of sensory nerve endings. So for nociception and for itching. That's why if we are having allergies, just think about H1 receptor. If we are having allergies na makatul, na maulol, so it is H1 mediated. It is the H1 receptor that is producing that effect. So it is an important component of the urticarial response and reaction of the skin to insect bites, especially bees. Okay, so some evidence suggests that local high concentration can also depolarize efferent nerve endings. So in the mouse and probably in humans, respiratory neurons signaling inspiration and expiration are modulated by H1 receptors. So this is not yet studied. It probably because it was observed in experiments with mouse, pero was not yet observed in humans. So it's still a possibility. So H1 and H3 receptors play important roles in appetite and satiety as well. So there are antipsychotic drugs which blocks these receptors, and they found out that it causes significant weight gain. So H1 and H3, as I mentioned, H1, it affects an effect was in for the pain and the itching. H3 receptor also participate as well in nociception, so in pain as well. For presynaptic H2 receptors, they play important roles in modulating release of several transmitters in the nervous system. So H3 agonists, they reduce the release of acetylcholine in various parts of the brain and as well as peripheral nerves. So an antagonist or inverse H3 agonist, pitolisant, appears to reduce drowsiness in patients with narcolepsy. For the cardiovascular system, the effect of histamine in the cardiovascular system, in humans, if we are going to inject histamine, there will be a decrease in the systolic and diastolic blood pressure and an increase in heart rate. These blood pressure changes are caused by the vasodilation of arterioles by the histamine due to the presence of histamine. So there will be flushing, a sense of warmth and headache, and this will occur during the administration of this histamine. This in small doses, this vasodilation is elicited, small doses of histamine. And this is mediated by the H1 mediated to and vasodilation if it's in small dose, if histamine is in small doses. However, if it is in higher doses, H2 receptor na it mag-mediate, since the process of vasodilation is due to the increase in CAMP as well as there is direct cardiac stimulation. So in humans, the cardiovascular effects of small doses of histamine can usually be antagonized by H1 receptor antagonists alone. H1 receptor antagonists, since small doses of histamine, the cardiovascular effect is mediated by the H1 receptor. If in higher doses, H2 mediated na yan. Unfortunately, what inhibitor an H2 if it is in higher doses. An H2 receptor blocker, Lanaton, is used for the gastric acid secretion and gastrointestinal system. Histamine-induced edema, which is also H1 receptor mediated, in the vessels of the microcirculation, especially the post-capillary vessels. So again, if the H1 receptor is being activated by histamine, there will be vasodilation. In other words, there will be separation of the endothelial cells, which will lead to transudation of fluid and molecules. Iba transudate. So it is the plasma. Plasma lang nagawas. Pero there can be also molecules that will be included, those who are small enough to pass through the gaps between the endothelial cells. Then this transudation is responsible for the urticaria or pangangatul, which also signals the release of histamine in the skin. Direct cardiac effects of histamine includes both increased contractility and increased pacemaker rate. So again, this happens only if there is a high amount of histamine present in the system. So when this histamine binds to the H2 receptors, this will increase the contractility and the pacemaker rate. If it is just small doses lang of the histamine, then it is mediated by the H1 receptors, and the tachycardia present in that effect is just due to the reflex tachycardia, because there will be decrease in blood pressure man if the H1 receptor was also activated, since there's vasodilation, decrease in total peripheral resistance, thus decreasing the blood pressure, which will lead to reflex tachycardia. Some of the cardiovascular signs and symptoms of anaphylaxis are due to released histamine, although several other mediators are involved and are much more important than histamine in humans. For the bronchiolar smooth muscles, this is also mediated by H1 receptors, so it causes bronchial constriction, and patients with asthma are very sensitive to histamine. Excuse me. Okay. The bronchoconstriction for these patients probably represents an hyperactive neural response, since for patients with asthma, they are already hyperresponsive to other stimuli. So for histamine, they are also very sensitive. The response to histamine can be blocked by autonomic blocking drugs such as ganglion blocking agents, as well as H1 receptor antagonists. Although methacholine provocation is more commonly used, tests using small doses of inhaled histamine have been used in the diagnosis of bronchial hyperactivity in patients with suspected asthma. Pero even the use of methacholine, baka hindi naman masyado ginihimo in the practice. Mostly clinical na pag-diagnose with asthma. Pero supposedly, we need to have a quantitative measurement to diagnose asthma. So for the GINA guidelines, we need to either do a spirometry or a peak flow meter para makita na variability. Anyway, okay. For the GI smooth muscle, the effect of histamine causes contraction of intestinal smooth muscle and histamine-induced contraction of guinea pig ileum, and it's a standard bioassay for this amine. However, the human gut, the smooth muscles of the gut, is not as sensitive to histamine. So large doses of histamine may cause diarrhea, partly as a result of this effect. Pero small doses of histamine may not have an effect to our GI smooth muscles. So this is also mediated by H1 receptors. Okay, for other smooth muscle organs, histamine has insignificant effects on the smooth muscle of the eye and the genitourinary tract. However, if the pregnant woman suffers anaphylactic reaction, abortion might ensue due to histamine-induced contractions. For secretory tissue, it is a powerful stimulant of gastric acid secretion, and to a lesser extent, the production of the gastric pepsin and intrinsic factor. So this one is mediated by H2 receptor on the gastric parietal cells, and is associated with increased CAMP, adenylyl cyclase activity, CAMP concentration, and the calcium concentration. So other stimulants of gastric acid secretion like the acetylcholine and gastrin do not increase CAMP, even though their maximal effects on acid output can be reduced but not abolished by H2 receptor antagonists. In other words, since there are other stimulants for gastric acid secretions, even though we are going to block the H2 receptors, there are still acid output. So it stimulates secretion in the small and large intestine. In contrast, H3 selective histamine agonists inhibit acid secretion stimulated by food or pentagastrin in several species. Histamine has much smaller effects on the activity of other glandular tissue at ordinary concentration. For very high concentration, it can cause catecholamine release from the adrenal medulla. For metabolic effects, recent studies of H3 receptor knockout mice demonstrate that the absence of this receptor results in increased food intake, decreased energy expenditure, and obesity. So it is not yet known if this has a similar role in humans. But there is research being done to determine whether if these H3 agonists are useful in the treatment of obesity. So the triple response. So the triple response means there is a characteristic red spot, edema, and flare response when there is an intradermal injection of histamine. And the effect involves 3 separate cell types. So this includes the smooth muscles in the microcirculation, the capillary or the venular endothelium, and the sensory nerve endings. So at the site of injection, there will be reddening, which is due to the dilation of the small vessels, then followed by an edematous wheal at the injection site and irregular flare surrounding the wheal. The flare is said to be caused by an axon reflex. That's why it's sensory nerve endings. A sensation of itching may also accompany these effects. So similar local effects may be produced by injecting histamine liberators like the compound 4880 and morphine intradermally or by applying the appropriate antigens to the skin of a sensitized person. Although most of these local effects can be prevented by adequate doses of H1 receptor blockers, H2 and H3 receptors may also be involved. So other effects possibly mediated by histamine receptors. Histamine may play a role in nociception in the CNS. Burimamide, an early candidate for H2 blocking action, and newer analogs with no notable effect on H1, H2, or H3 receptors have been shown to have significant analgesic action in rodents when administered into the central nervous system. The analgesia is said to be comparable to that produced by opioids, but tolerance, which is addiction, being addicted to the drug, respiratory depression, and constipation have not been reported. So, small substitutions on the imidazole ring of histamine significantly modify the selectivity of the compound for the histamine receptor subtypes. For clinical uses, as I have mentioned a while ago, it is sometimes it was used as a provocative test for bronchial hyperactivity. Pero methacholine is commonly used rather than histamine. And histamine has no other current clinical applications. For its toxicity, adverse effects of histamine release are dose-related. So larger doses means larger adverse effects. So we have flushing, hypertension, tachycardia, headache, urticaria, bronchoconstriction, and gastrointestinal upset, which will include diarrhea. These effects are also observed after the ingestion of spoiled fish. So we call that as scombroid fish poisoning, or scombroid for short. And histamine produced by bacterial action in the flesh of improperly stored fish is the major causative agent. Because what is happening here is mostly the fish that is in question here is those that have high levels of histidine already, like the tuna, sardines, they have high levels of histidine. So if there is improper storage, the bacteria can convert this histidine to histamine. Unfortunately, even though we cook it in order to eliminate the bacteria, it will not eliminate the histamine, the substance. So, yun. Diagnosis for this is typically based on the symptoms. And if there is a number of people who eat the same fish and they develop symptoms, then highly likely, and if the fish is known to have high levels of histidine, then most likely that is from broiled fish poisoning. So histamine should not be given to patients with asthma as well, since it causes bronchoconstriction, except as a part of carefully monitored test of pulmonary functions, or to patients with active ulcer disease or GI bleeding, since histamine will increase the gastric acid, which would lead to more ulceration of the mucosa, as well as if there is bleeding, then it would aggravate the bleeding. Okay, so for histamine antagonists, we have physiologic antagonists like the epinephrine, have smooth muscle actions opposite to those of histamine, but they act at different receptors. This is important clinically because injection of epinephrine can be life-saving in systemic anaphylaxis. That's what we use in anaphylaxis, epinephrine. And in other conditions in which massive release of histamine and other more important mediators occurs. We also have release inhibitors, which reduces the degranulation of mast cells that results from immunologic triggering by antigen IgE interaction. We have promoline and nidocromil. This has been used in the treatment of asthma. We also have beta-2 agonists, also capable of reducing histamine release. Sakto lang because beta-2 agonist is part of the medication used in asthma. We have the SABA, LABA, short-acting beta-agonist, and the long-acting beta-agonist. But right now, based on the GINA guidelines, it is recommended to have steroids aside from beta-agonist in the treatment of asthma. Histamine receptor antagonists represent a third approach to the reduction of histamine-mediated responses. So the development of selective H2 receptor antagonists has led to more effective therapy for peptic disease. However, H2 receptor antagonist is not really the first line or mostly the one that is being used for peptic disease. What we use is proton pump inhibitor like the omeprazole. Okay. So selective H3 antagonists or inverse agonists like the pitolisant is approved for the treatment of narcolepsy. H4 antagonists are not yet available for clinical use. However, potent and partially selective experimental H3 receptor antagonists like the thioperamide and clobenfropid have been developed. Okay, so for histamine receptor antagonists, we have H1 receptor antagonists. These are compounds that competitively block histamine or act as inverse agonists at H1 receptors and have been used in the treatment of allergic conditions for many years. The H1 antagonists are divided into first generation and second generation agents. They are differentiated or they are distinguished because by the relatively strong sedative effects of the first generation drugs. That's why first generation drugs are not used anymore commonly for para mga allergic rhinitis, mga solitone, because it has strong sedative effect. Whereas the first generation agents are also more likely to block autonomic receptors. So what we use is the second generation H1 blockers since it is less sedating. Since it does not distribute that freely into the central nervous system. Okay. So we have here a general structure of the H1 antagonist drugs. and examples of the major subgroups. So we have the alkylamine derivative, the ethanolamine derivative, and the piperidine derivative. For these three derivatives, the piperidine derivative is the one that belongs to the second generation of antihistamines. Okay, so we have the table here, which shows the different derivatives as well as the specific medications. There are the usual adult dose and the anticholinergic activity and some comments. So as you can see here, first generation antihistamine has sedation effects. Unlike in second generation, although cetirizine is part of the second generation antihistamine, it doesn't mean that it doesn't have any sedative effect. Di ba? Pinamimiraw kita pag natumal kita sa cetirizine. Pero compared with loratadine, loratadine has a lesser sedative effect compared to cetirizine. But first generation antihistamines, amo itong talagang may sedative effect. For the chemistry and pharmacokinetics, rapidly absorbed after oral administration. So the peak blood concentrations is 1 to 2 hours. It is widely distributed throughout the body, and the first generation H1 blockers enters the CNS readily. So they don't have trouble in the blood-brain barrier. Some are extensively metabolized and is primarily by microsomal systems in the liver. Several of the second generation agents are metabolized by the CYP3A4 system and thus are subject to important interaction with when other drugs like the ketoconazole inhibit this subtype of P450 enzyme. So may you call this it is important pala, you should know the different substances that induces induces and inhibits the cytochrome P450. So yun, kindly review that. If I'm not sure kung na-encounter na niyo ito nga mga substances like the grapefruit juice, ketoconazole, na-encounter na ba niyo? Sige lang, ma-review man lang kapit niyo by the time na kailangan niyo mag-take in board exam, I mean. Okay, so where am I? Okay, so most have an effective duration of action of 4 to 6 hours after a single dose. Meclizine and several second generation agents are longer acting, like the loratadine, with a duration of action of 12 to 24 hours. So mas longer ang effect. The newer agents are considerably less lipid soluble than the first generation drugs. That's why they don't cross the blood-brain barrier, so they have lesser sedative effects. And other agents are substrate of the P-glycoprotein transporter, which is in the blood-brain barrier. That's why they are broken down. They are unable to pass through the blood-brain barrier. So many H1 antagonists have active metabolites. So for hydroxyzine, derphenadine, and loratadine, their active metabolites are cetirizine, fexofenadine, and desloratadine. Okay. Both neutral H1 antagonists and inverse H1 agonists reduce or block the actions of histamine by reversible competitive binding to the H1 receptor. They have negligible potency of the H2 receptor and little of the H3 receptor. So medyo selective hira ha H1 receptor. For example, Histamine-induced contraction of bronchiolar or GI smooth muscle can be completely blocked by these agents, but histamine-stimulated gastric acid secretion and the stimulation of the heart are unaffected, since again, um, the, the stimulation of the gastric acid secretion is mediated by the H2 receptor. And the stimulation of the heart, if it is in large doses of histamine, it is mediated by the H2 receptor as well. So there is no effect for the H1 antagonists. For sedation, a common effect of first generation H1 antagonist is sedation, first generation. But the intensity of this effect varies depending on the drug or the molecule and the individual. The effect is sufficiently prominent with some agents, that's why they are used as sleeping aids. And the effect resembles that of some antimuscarinic drugs and is considered very different from the disinhibited sedation produced by sedative hypnotic drugs. And aside from that, this first-gen H1 antagonist does not cause addiction, unlike the sedative hypnotic drugs. So here, again, the table for the antihistamine drugs that is in clinical use. At ordinary doses, children occasionally manifest excitation rather than sedation. And at very high toxic dose levels, there is a marked stimulation, agitation, and even seizures, which can lead to coma. For second generation H1 antagonists, they have little or no sedative or stimulant action. These drugs also have a far fewer autonomic effects than the first generation antihistamine. There are several first generation H1 antagonists that is also used as antiemetic. So like doxylamine, they were used widely for the treatment of nausea and vomiting in pregnancy. Although this product was withdrawn in 1983, there is combination of doxylamine and pyridoxine that was approved by the US FDA in 2013 for the same purpose, for the treatment of nausea and vomiting of pregnancy. There is also anti-Parkinson effects for this H1 receptor antagonist. So like diphenhydramine, these have significant acute suppressant effects on the extrapyramidal symptoms when it is due to antipsychotic drugs. It is an effect of antipsychotic drugs. If given parenterally, it is also used for acute dystonic reactions to antipsychotics. Antimuscarinic actions, so many first-gen agents, especially those of the ethanolamine and ethylenidiamine subgroups, have significant atropine-like effects on peripheral muscarinic receptors. This action may be responsible for some of the benefits reported for the non-allergic rhinorrhea, but may also cause urinary retention and blurred vision. It also has adrenal blocking actions. It can be demonstrated for many H1 antagonists, especially those in the phenothiazine group, like the promethazine. This action may cause orthostatic hypotension in susceptible individuals, and beta receptor blockade is not significant for the H1 receptor antagonists. It also has serotonin blocking action, so it has a strong blocking effect for the receptors for serotonin, and these have been demonstrated in some first-gen H1 antagonists like the cyproheptadine. This drug is promoted as an anti-serotonin agent and is discussed with that drug group. Nevertheless, its structure resembles that of the phenothiazine antihistamine and is a potent H1 blocking agent, although it is primarily used for anti-serotonin. Local anesthesia. It is also used as potent local anesthetic since they can block sodium channels in excitable membranes in the same fashion as lidocaine and procaine. Diphenhydramine and promethazine are actually more potent than procaine as local anesthetic. Occasionally used to produce local anesthesia if the patient is allergic to conventional or the one that is commonly used local anesthetic drugs. And there's a small number of these agents also block potassium channels. Cetirizine, certain H1 antagonists like cetirizine, they inhibit the mast cell release or the mast cell degranulation for histamine and some other mediators of inflammation. The action is not due to blockage or the blockade of H1 receptor and may reflect as an H4 receptor effect. The mechanism is not fully understood but could play a role in the beneficial effect of these drugs in the treatment of allergies such as rhinitis. A few H1 antagonists, like the terfenadine and aclifostin, have been shown to inhibit the P-glycoprotein transporter found in cancer cells, the epithelium of the gut, and the capillaries of the brain. First gen are still commonly used over-the-counter drugs. The prevalence of allergic conditions and the relative safety of the drugs contribute to this heavy use. Relative safety in a sense that it is still sedative. So mostly, mga natumar hini, kapti natumar. However, the fact that they do cause sedation contributes to use of older agents as nighttime sleep aids, as well as increasing over-the-counter use of the second-gen antihistamine to avoid the sedative action. So the H1 antihistaminic agents are the first drugs used to prevent or treat the symptoms of allergic reactions. Diba kung may nahinatsingon or may na plano magkaon ira allergic hira, nasing nga matumarian si cetirizine. So cetirizine again is an H1 antihistaminic agent. In allergic rhinitis, H1 antagonists are second-line drugs after glucocorticoids administered by nasal spray. But in the Philippine guidelines, clinical practice guidelines, by the Society of ENT, they still use the H1 antagonist as the first-line drug. In urticaria, the H1 antagonists are the drug of choice. In bronchial asthma, H1 antagonists are largely ineffective. This again, asthma is not only triggered by histamine, it can also be triggered by other substances, by other stimuli. So, use of H1 antagonist does not really have that much. Clinical uses. Angioedema may be precipitated by histamine release, but appears to be maintained by peptide kinase that are not affected by antihistamine agents. So for atopic dermatitis, antihistamine drugs like diphenhydramine are used mostly for their sedative side effects. H4 antihistamines may supplant the H1 antagonist in atopic dermatitis. The H1 antihistamines used for treating allergic conditions such as allergic rhinitis or hay fever are usually selected with the goal of minimizing the sedative effect. However, sedative effect and the therapeutic efficacy of different agents vary widely among individuals because there are some that has better effect haira and sana molecule rather than the other. Then the second generation H1 antagonists are used mainly for the treatment of allergic rhinitis and chronic urticaria. In addition ngayon, the clinical effectiveness may diminish with continued use. So kung permit-permit lang mag-ignore yung cetirizine, there might be a time na bagandiri daganhain mo. So switching to another group, like for example, if you're using cetirizine right now, switching to another group like loratadine may restore the drug effectiveness of the cetirizine. However, the reason for that is still unknown. For the motion sickness, it is also H1 receptor antagonist is also used for motion sickness as well as anti-emesis. So scopolamine and certain first-gen H1 antagonists are the most effective agents available for the prevention of motion sickness. Antihistamine drugs with greatest effectiveness in these applications are the difen and the promethazine. But there is also the dimenhydrinate, which is a salt of diphenhydramine. It has similar efficacy with diphenhydramine for the treatment of motion sickness. The piperazines like the cyclizine and the meclizine also have significant activity in the prevention of motion sickness, and they are less sedating than diphenhydramine. And the dosage used for motion sickness is also the same as the one recommended for the allergies. It has also been claimed that prophylaxis use of these medications for motion sickness are also useful in Meniere's syndrome, pero it is not yet established. For the nausea and vomiting of pregnancy, dati it was the piperazine derivatives that was used, but they were now withdrawn because it was demonstrated that in rodents it can cause cancer. Doxylamine, an ethanolamine H1 antagonist, is promoted for this application as a component of bendectin, a prescription medication that is also contains pyridoxine, because pyridoxine also shows an effect that it helps in the morning sickness of pregnant patients. However, World Health Organization recommendation says that the supplementation for pyridoxine is not recommended for pregnant women for the improvement of maternal and perinatal outcomes. So less common toxic effects, we have excitation and convulsions in children, postural hypotension, and allergic responses. Drug allergy is relatively common after the topical use of H1 antagonists. The effect of severe systemic overdosage of the older agents resemble those of atropine overdosage, and overdosage of astemizole or terfenadine may induce cardiac arrhythmias. That's why astemizole and terfenadine are also withdrawn from the market as well. They are no longer marketed in the USA. Lethal ventricular arrhythmias occurred in several patients taking either of the early second-generation agents like the terfenadine or astemizole, again withdrawn from the market, and in combination with ketoconazole, itraconazole, or macrolide antibiotics. Because once again, as I mentioned kanina, these are inhibitors in the metabolism of many drugs by the P450 enzyme. So this includes the ketoconazole, itraconazole, macrolides, as well as grapefruit juice. Grapefruit juice also inhibits. In other words, what happens here is there will be increased concentration of the terfenadine and the astemizole in the body, which will lead to the lethal ventricular arrhythmia. So the mechanism of this toxicity involves the blockade of the potassium channels in the heart, and the result is the prolongation of the action potential, which can lead to arrhythmia. For the H2 receptor antagonist, these drugs are discussed more in the later chapter, which talks about the drugs used in the treatment of the gastrointestinal disease, since it is mostly used there, like the peptic ulcer disease. Then the development of the H2 receptor antagonist was based on the observation that H1 antagonist does not have any effect in the acid secretion of the stomach, even though it is histamine induced. So that's how the H2 receptor antagonist came to be. Okay. So the high prevalence of peptic ulcer disease created great interest in the therapeutic therapeutic potential of the H2 receptor antagonist when first discovered. Although these agents are not the most efficacious available, their ability to reduce gastric acid secretion with very low toxicity has made them extremely popular as over-the-counter preparations. But right now, what we use is the proton pump inhibitor, which includes omeprazole. Okay, so molecular manipulation of the histamine molecules resulted in drugs that block acid secretion, and there is no H1 receptor effect, maybe agonist or antagonist. And the high prevalence of the peptic ulcer disease created this great interest in the use of the H2 receptor antagonist. Na-mention ko na yun. Okay. Although for H3 and H4 receptor antagonists, although there is no selective H3 or H4 ligands that is presently available for clinical use, there is great interest in the potential for these antagonists. And H3 selective ligands may be of value in sleep disorders, narcolepsy, obesity, and cognitive and psychiatric disorder because we have already found an agonist, the triptolizan, which has shown to reduce sleep cycles in mutant mice and in humans with narcolepsy. Increased obesity has also been demonstrated in both H1 and H2 receptor knockout mice. However, H2 inverse agonists decrease feeding in obese, mouse models. So again, H and H4 receptors are like the same. And so in other words, we have affinity for H3 ligands to the H4 receptors. H4 blockers have potential in chronic inflammatory conditions such as asthma, in which eosinophils and mast cells play a prominent role. However, there is no selective H4 ligands, agonists or antagonists available for use in humans. And however, many H1 selective blockers like the difen, cetirizine, and loratadine also show some affinity for the H4 receptor. And several studies have suggested that H4 receptor antagonists may be useful in pruritus, asthma, allergic rhinitis, and pain conditions. So that's it for the histamine. We proceed with serotonin. For serotonin, before the identification of the exact molecule, the 5-hydroxytryptamine, it was already known that serotonin is a substance that is released from the clot into the serum in order for the blood to clot. It is a vasoconstrictor substance that is released from the clot into the serum. And there is also another substance known as enteramine, which is believed to stimulate the smooth muscle of the intestinal mucosa. It was then known when the 5-hydroxytryptamine was identified, it was already known that serotonin and enteramine is the same metabolite na ngayon of the 5-hydroxytryptophan. So serotonin is an important neurotransmitter. It is also a local hormone in the gut and also a component of the platelet clotting process. So it is thought to play a role in migraine headache and several other clinical conditions, which includes the carcinoid syndrome. Carcinoid syndrome is a syndrome manifested by the presence of the carcinoid tumor. A carcinoid tumor is a neoplasm of the enterochromaffin cells. Okay. So in patients whose tumor is not surgically resectable, a serotonin antagonist may constitute a useful treatment since a neoplasm, a carcinoid tumor produces serotonin. So an antagonist for that will be beneficial, especially if you cannot resect the carcinoid tumor. For the chemistry and pharmacokinetics, like histamine, serotonin is widely distributed in nature. It is found in plants, animal tissues, venom, stings, and it is synthesized in biological systems from the amino acid tryptophan, and it is being hydroxylated in order to produce the 5-hydroxytryptamine or the serotonin. And serotonin can then be converted into melatonin. So after synthesis, the free amine, the serotonin, it is stored in vesicles, or it is also rapidly inactivated like the histamine. And it is usually by the monoamine oxidase. In the pineal gland, serotonin is a precursor of the melatonin, a melanocyte-stimulating hormone that has complex effects in several tissues, which includes the circadian rhythm. In humans, over 90% of the serotonin in the body is found in the enterochromaffin cells in the GI tract. In the blood, serotonin is found in the platelets, which are able to concentrate the amine by means of an active serotonin transporter mechanism, similar to that of the membrane of the serotonergic nerve endings. Once transported into the platelet or nerve endings, the serotonin is concentrated in vesicles by a vesicle-associated transporter, which can be blocked by resorpine. Serotonin is also found in the raphe nuclei of the brainstem, which contains cell bodies of serotonergic neurons, wherein it is where they synthesize, store, and release serotonin as a neurotransmitter. Okay, so brain serotonergic neurons are involved in numerous diffuse functions such as mood, sleep, appetite, and temperature regulation, as well as the perception of pain, regulation of blood pressure, and vomiting. It is also clearly involved in psychiatric depression and also appears to be involved in conditions such as anxiety and migraine. So you will experience that when if you're going to the what you call this break ship. SSRIs are often given for this psychiatric depression. Serotonergic neurons are found in the enteric nervous system of the GI tract and around blood vessels. The function, however, in the enterochromaffin cells is not fully understood yet. So these cells synthesize serotonin, store the amine in a complex with adenosine triphosphate and other substances in granules, and release serotonin in response to a mechanical and neuronal stimuli. Please don't be confused with the enterochromaffin cells and the enterochromaffin-like cells. Okay, the enterochromaffin cells, that's the one that produces the serotonin. The enterochromaffin-like cells produces histamine. Okay, some of the released serotonin diffuses into blood vessels and is taken up and is stored in platelets. Serotonin is metabolized by the monoamine oxidase, and the intermediate product is further oxidized by aldehyde dehydrogenase to 5-hydroxyindole acetic acid. In humans consuming a normal diet, the excretion of the 5-HIAA is a measure of serotonin synthesis. So this substance is being used as a diagnostic test in order to identify if a patient has a carcinoid tumor. The actions of serotonin are mediated through a remarkably large number of cell membrane receptors. So there are 7 families of 5-HT receptor subtypes, which is given the subscripts 1 to 7, 6, in which 6 are G protein coupled receptors, while the other one is a ligand-gated ion channel receptor. So here's the table of the receptor subtypes. So we can see here their distribution as well as the post-receptor mechanism. The 5-HT3 is the only one that is different. This is the ligated ion channel, while the others are G protein coupled receptors. Now we go to the effects of serotonin. First, we have the nervous system. So it is present in a variety of sites in the brain, especially in the pineal gland, since it is a precursor of melatonin. Its role is as a neurotransmitter will be discussed in later chapters na lang. Replinotan, it is a 5-HT1A agonist, currently in clinical trials, and it appears to have some anti-nociceptive action at higher doses while reversing opioid-induced respiratory depression. So 5-HT3 receptors in the GI tract and in the vomiting center of the medulla participate in the vomiting reflex. So they are important in vomiting caused by chemical triggers like the cancer chemotherapy drugs. We also have the 5-HT1P receptors as well as the 5-HT4. They play an important role in the enteric nervous system function. So like histamine, serotonin is a potent stimulant of pain and itch sensory nerve endings. Hence, they are responsible for the symptoms caused by insect sting and plant stings. Serotonin is also a powerful activator of chemosensitive endings located in the coronary vascular bed. Activation of the 5-HT3 receptors on the afferent vagal nerve endings is associated with the chemoreceptor reflex known as the Bezold-Jarisch reflex. So, Bezold-Jarisch reflex is a cardioinhibitory reflex wherein it is caused by venous pooling, can be caused by stress, it can be caused by pain. And the triad, duwala kasi ng butangadi, the triad for this Bezold-Jarisch reflex is marked bradycardia, hypotension, as well as peripheral vasodilation. However, the physiologic role for this reflex is not yet noted. The bradycardia is mediated by the vehicle outflow to the heart and can be blocked by atropine. The hypotension is a consequence of the decrease in cardiac output that results from bradycardia. A variety of other agents can also activate this chemoreceptor reflex. This can include the cardiac glycosides as well as nicotinic receptor agonists. Although serotonergic neurons are not found below the site of injury to the adult spinal cord, constitutive activity of serotonin receptors may play a role following such a lesion. So the administration of serotonin blockers appears to reduce spasms following this type of injury. For the melatonin pharmacology, melatonin is again its precursor is serotonin. It is an N-acetyl-5-methoxytryptamine, a simple methoxylated and N-acetylated product of serotonin found in the pineal gland. It has been characterized in the central nervous system and several peripheral tissues, its receptors, I mean. And in the brain, there are two receptors, the MT1 and the MT2 receptors, which is found in the suprachiasmatic nucleus of the hypothalamus, which is associated with the circadian rhythm. So MT1 and MT2 are G protein coupled receptors as well, with the alpha subunit GI as the one being released. A third receptor, MT3, is an enzyme. It binds to the site and it has poorly defined physiologic role, which is possibly related to intraocular pressure. The activation of MT1 receptor will result to sleepiness, while the MT2 receptor is related to the light-dark synchronization of the biologic circadian clock. Melatonin is used clinically. So there's supplement, diba? If you can remember, there are supplements known as melatonin. It helps in to have good sleep. So it is used in oral doses of 0.5 to 5 milligram and usually administered at bedtime. Ramelteon is a selective MT1 and MT2 agonist that is approved for the treatment of insomnia. This drug has no addiction liability, and it appears to be distinctly more efficacious than melatonin as a hypnotic. Pero benzodiazepine is still stronger and is still efficacious compared to ramelteon. It is metabolized by the P450 enzyme. So in other words, make sure lang that when you take the ramelteon, you are not taking other medications like ciprofloxacin, acyclovir, allopurinol, which can inhibit the P450 enzyme. Hence, ramelteon concentration, drug concentration will be increased. So melatonin has a half-life of 1 to 3 hours and an active metabolite with a half-life of up to 5 hours. Ramelteon may increase prolactin levels as well. So there is also tasimelteon. It is a newer MT1, MT2 agonist which is approved for non-24-hour sleep-wake disorder, and agomelatine, an MT1, MT2 agonist, as well as a 5-HT2C antagonist, which is approved for major depressive disorder. In the respiratory system, small direct stimulant effect on bronchial smooth muscle in normal humans, probably due to the activation of the 2A subtype of serotonin receptors. It appears to facilitate acetylcholine release from the bronchial vagal nerve endings, and in patients with carcinoid syndromes, episodes of bronchoconstriction occur in response to the elevated levels of the amine or peptides released from the tumor. Serotonin may also cause hyperventilation as a result of the chemoreceptor reflex or stimulation of bronchial sensory nerve endings. For the cardiovascular systems, there will be contraction of vascular smooth muscles, primarily mediated by the subtype 2 of the serotonin receptors. It is a powerful vasoconstrictor except in skeletal muscles and the heart, where it dilates blood vessels. At least part of the serotonin-induced vasodilation requires the presence of vascular endothelial cells. When the endothelium is damaged, coronary vessels are constricted by the serotonin. Serotonin can also elicit reflex bradycardia by activating of the subtype 3 receptors on the chemoreceptor nerve endings. So studies in knockout mice suggest that the serotonin, which acts on the 1A, 2, and 4 subtype receptors, is needed for the normal cardiac development of the fetus. On the other hand, if adults are chronically exposed to agonists for subtypes 2B receptor, it is associated with valvulopathy. Adult mice lacking the 2B subtype receptor of serotonin is protected from cardiac hypertrophy. There are also preliminary studies that suggest that the 2B antagonists can prevent development of pulmonary hypertension in animal models. Serotonin also constricts veins. Venoconstriction with increased capillary filling appears to be responsible for the flush that is observed after serotonin administration or release from a carcinoid tumor. Serotonin has a small direct positive chronotropic and inotropic effects on the heart, which are probably of no clinical significance. However, prolonged elevation of the blood levels of serotonin is associated with pathologic alterations in the endocardium, which can result into valvular or electrical malfunction. Serotonins can also cause blood platelets to aggregate by activating the HT2 receptors. This response, in contrast to aggregation inducing during normal clot formation, is not accompanied by the release of serotonin stored in the platelets. The physiologic role of this effect is actually unclear yet. Serotonin is also a powerful stimulant of GI smooth muscles. It increases the tone and facilitates the peristalsis. The action is caused by the direct action of serotonin on the HT2 smooth muscle receptors, plus a stimulating action on ganglion cells located on the enteric nervous system. So the receptors that may be involved here is the 1A and the 7 receptors. The activation of the HT4 receptor in the enteric nervous system causes the increased acetylcholine release, wherein it mediates a motility-enhancing or prokinetic effect of selective serotonin agonists such as cisapride, and these agents are useful in several GI disorders. Basically, serotonin has little to no effect on the secretions. So, and if there is effect, mostly it is inhibitory. Okay. For the GIT, done now. Sorry. For the skeletal muscle and the eye, we have the serotonin syndrome. So, as serotonin syndrome is associated with skeletal muscle contraction, it is precipitated when there is monoamine oxidase inhibitor and is being given with serotonin agonist. Again, serotonin is degraded by this monoamine oxidase inhibitor, monoamine oxidase. And if this is inhibited, plus there is agonist which produces more serotonin, then yun na, there will be serotonin syndrome since there's a large concentration of serotonin in the body. So especially antidepressant of the SSRI class. Although the hyperthermia of serotonin syndrome results from excessive muscle contraction, serotonin syndromes is probably caused by a central nervous system effect of the drug. So studies in animal models of glaucoma indicate that the 5-HT2A agonists reduce intraocular pressure. This action can be blocked by ketanserin and similar 5-HT2 agonists. The presence of the 5-HT2 receptors are not yet understood kung ano ang physiological role. So here is a table for the characteristics of serotonin syndromes and other hyperthermic syndromes. So we have serotonin syndrome, neuroleptic malignant syndromes, and malignant hyperthermia. So these three, may pwede magkalipat-lipat it doctors if which one. So we just have to know the precipitating drug. Kasi if it is malignant hyperthermia, for example, is often encountered during prior to surgery and during after the injection of the anesthesia. So in order for us to differentiate the three syndromes, we need to determine which drug that was used, which causes the syndrome. Another thing, kasi we need to have there are different treatment for each syndrome. For example, for serotonin, we can give benzodiazepine, while for neuroleptic, we can give difen. For malignant hyperthermia, we have dantrolene. Okay, so excess synaptic serotonin causes a serious, potentially fatal syndrome that is diagnosed on the basis of history of the administration of the drug within recent weeks and physical findings. It has some characteristics in common with neuroleptic malignant syndrome and malignant hyperthermia, because the three of them has hyperthermia. As suggested by the drugs that precipitate it, serotonin syndrome occurs when there is overdose with a single drug, or there is a concurrent use of several drugs, which result in the excess serotonergic activity. So basically, damo ang serotonin halawas. As I have mentioned a while ago, pwede overdose lang yan on usang drug. Pwede like a serotonin agonist, which produces more serotonin in the body, or they use a combination of the serotonin agonist and the inhibitor of the monoamine oxidase. It is predictable and not idiosyncratic, but milder forms may easily be misdiagnosed. In animal models, many of the signs of the syndrome can be reversed by the administration of the antagonist. However, other receptors may be involved as well, so dantrolene is of no value unlike the treatment of a malignant hyperthermia. Okay, so neuroleptic malignant syndrome is idiosyncratic rather than predictable and appears to be associated with hypersensitivity to the Parkinsonism-inducing effects of the dopamine 2 receptor blocking antipsychotics in certain individuals. The malignant hyperthermia is associated with a genetic defect in the calcium channel of skeletal muscle sarcoplasmic reticulum that permits uncontrolled calcium release from the sarcoplasmic reticulum when precipitating drugs are given. Buspirone, it is an agonist, has received attention as an effective non-benzodiazepine anxiolytic. Appetite suppression appears to be associated with agonist action at 5-HT2C receptor in the CNS. Dexpemfluramine, which is a selective 5-HT agonist, is widely used as an appetite suppressant, but was withdrawn because of cardiac valvulopathy. We now have lorcaserin, a 5-HT2C agonist, which is approved by the FDA in 2012 as a weight loss medication. However, just this January 2020, the FDA alerted the public about a possible risk of cancer associated with this medication, based on the preliminary analysis of the clinical trial. That's why they requested the withdrawal of the lorcaserin in the market. By the way, it was branded as Belvic, the lorcaserin. So treatment of obesity. So it is said that the world is experiencing what we call an epidemic of obesity, since most population all over the world in many countries is above the optimal weight, and that the excess weight is often associated, mostly right now, is associated with metabolic syndromes, which means there's increased risk of cardiovascular disease and diabetes. Although obesity can be defined as an excess adipose tissue, the current quantitative measurement for obesity is the body mass index, wherein it's calculated as the weight in kilograms over the height raised to 2 in meters. Using this measure, the range would be this. However, this is not the range used by Filipinos, since we are following the Asia Pacific guidelines. So for us, underweight is less than 18.5, normal is at 18.5 to 22.9, overweight would be 23 to 24.9, while obese is more than 25. But it doesn't mean that we're just focusing in for obesity nga at obesity that may the mga obese patients that may the risk for getting sick. Underweight people also have an increased risk of health problems, but it is smaller compared to obese individuals. And there are also some individuals like bodybuilders. They are very muscular, So their BMI can be on the level of obese, but there's no excess fat. So that is one of the questions that we're having for the for the BMI, if it really is an indicator for obesity, since yun nga, there are people, there are individuals who have this very muscular build, which contributes, the muscle mass contributes to the weight. And because of that, there is a second metric that was promoted, which may be an even better predictor of cardiovascular risk. So we have the waist measurement to body height ratio. And if the ratio is less than 0.5, then there is lower cardiovascular risk. Experts consider drug therapy to be justified in patients with an increased risk factor and a BMI of more than or equal to 27, and in those without comorbidities but with a BMI of more than or equal to 30. But again, BMI more than or equal to 30, that's the WHO guideline for obese. However, in Filipinos, we consider obese if it is already more than or equal to 25. So the cause of obesity can be simply stated as this: energy intake. So the intake of the dietary calories exceeds or is more than the energy output. The energy output comprising the resting metabolism, the exercise or the activity of the individual. But the actual physiology of weight control is extremely complex, and the pathophysiology of obesity is still poorly understood. Many hormones and neuronal mechanisms regulate the intake, the processing, and output. Intake, which includes the appetite, the satiety, which is more of neuronal; processing, which includes the absorption, the conversion to fat, and the glycogen production; and the output, which is the thermogenesis and the muscle work. The social and psychological aspects of eating are powerful influences that are independent or only partially dependent on the physiologic control mechanism. So yun, it also plays a part, the social aspect, since sometimes napipilitan nila kumaon kay nakikipangaon ng kaupod, di ba? Mga soliton. So for the treatment, we have the bariatric surgery. So gastric bypass, in other words. It readily achieves a sustained weight loss of 10 to 40%. But even a 5 to 10% loss of weight is associated with reduction in blood pressure and improved glycemic control. The GI flora also influence metabolic efficiency. So there's a research in mice that suggests that if we alter the microbiome or the GI flora in our stomach, it can lead to weight gain or weight loss. The most popular and successful appetite suppressants were the non-selective 5-HT2 agonists, the fenfluramine and the dexfenfluramine. Wherein in combination with phentermine, it is known as fenfen and dexfen, and they were moderately effective. However, they cause pulmonary hypertension and cardiac valve defects. Other drugs like the phenylpropanolamine, benzphetamine, amphetamine, methamphetamine, phentermine, and diethylpropion, mazidone, phendimetrazine are available in most countries. These are older drugs that is used as appetite suppressant. These are all amphetamine mimics and CNS appetite suppressant. However, their toxicity is significant, and it includes hypertension with a risk of cerebral hemorrhage, and as well as addiction liability, especially the methamphetamine. Liraglutide, lorcaserin, orlistat, and phentermine are the only single-agent drugs that is currently approved in the USA for the treatment of obesity. However, um, these do not produce more than a 5 to 10% loss of weight. In addition, combination agents like the phentermine plus topiramate and naltrexone plus glucoprion are available. So we have here the different anti-obesity drugs and their effects, as well as the dosages used and the toxicity noted if in overdosage. So clinical trials and phase 4 reports suggest that these agents are modestly effective for the duration of therapy and are probably safer than the single agent amphetamine mimics. So again, they do not produce more than a 5 to 10% loss of weight. We have also mirabegron, which is a beta-3 agonist that is approved for the treatment for overactive bladder and is possibly a future interest because beta-3 agonist activates the brown fat to consume more energy. However, in adults, brown fat is mas kutin na lahiya compared in infants. So I'm not sure how effective this would be. Okay, so for the 5-HT1D1B agonist, like the sumatriptan, is used almost exclusively for migraine headaches. So migraine in its classic form is characterized by an aura of variable duration, which includes nausea, vomiting, visual scotomas, or even hemianopsia, and as well as speech abnormalities. This aura is followed by a severe throbbing unilateral headache that lasts for a few hours to 1 to 2 days. The common migraine lacks the aura phase, but the headache is similar, so it is a unilateral headache. Migraine involves the trigeminal nerve distribution to intracranial and possibly extracranial arteries. These nerves release peptide neurotransmitters, which is known as the calcitonin gene-related peptide. And this peptide is an extremely powerful vasodilator. The substance P and neurokinin A may also be involved. And since calcitonin gene-related peptide is a vasodilator, there will be extravasation of the plasma and plasma proteins into the perivascular space. And this effect possibly reflects the action of the neuropeptides on the vessels. So the mechanical stretching caused by this edema may be the immediate cause of the activation of nociception in the dura. The onset of headache is sometimes associated with a marked increase in amplitude of the pulsation of the temporal artery. So, amo ito niya throbbing headache in migraine, nagpuputok-putok, amo ito. That is the temporal artery pulsation. And relief of pain through the use of therapy or medication is sometimes accompanied by the diminishing pulsations of this temporal artery. The mechanism of action of drugs just in migraine are still poorly understood because it is a wide variety of drug groups and actions, different drug groups, different actions, or different effects. So yun, in addition to the triptans, these include the ergot alkaloids, the NSAIDs, beta blockers, calcium channel blockers, tricyclic antidepressants, SSRIs, and several anti-seizure agents. They are all used. They can all be used for migraine headaches. However, some of these drug groups are only effective for prophylaxis and not for the actual attack of the migraine. The two primary hypotheses that was proposed to explain the action of the drugs, first, that triptans, ergot alkaloids, and antidepressants may activate the 5-HT1D or 1B receptors on the presynaptic trigeminal nerve endings, which inhibits the release of the vasodilating peptides. That's how they act on the migraine headache. For the anti-seizure agents, they suppress the excessive firing of the nerve endings. Second, the vasoconstrictor actions of the direct serotonin agonists like the triptans and the ergot, they may prevent vasodilation and stretching of the pain endings. Sumatriptan and its congeners are currently first-line therapy for acute severe migraine attacks in most patients. However, they should not be used in patients at risk for coronary artery disease. So here is a figure showing an effect of sumatriptan versus placebo on symptoms of acute migraine headache 60 minutes after injection of 6 milligrams subcutaneously. So there is a significant difference between placebo and sumatriptan. By the way, for modern researchers, we do not, they're not here allowed to use placebo versus the molecule. What we do is the molecule that is being researched versus the standard of care, because we don't for the ethics of the clinical trial, we should give the patient the standard of care and not just placebo. Anyway, off topic. Okay, so anti-inflammatory analgesics like aspirin and ibuprofen are often helpful in controlling the pain of the migraine. For patients with very severe nausea and vomiting, metoclopramide can be helpful since metoclopramide is antiemetic. Sumatriptan and other triptans are selective agonists for the serotonin 1B and 1B subtype receptors. These receptor types are found in the cerebral and meningeal vessels and mediate vasoconstriction. They are also found on neurons and probably function as presynaptic inhibitory receptors. And in population studies, all of the triptans, serotonin agonists are as effective or more effective in migraine than other acute drug treatments like the ergot alkaloids. So here are the different types of triptans. For the adverse effects, triptans can cause altered sensations, dizziness, muscle weakness, neck pain, and injection site reactions if the triptan is parenteral, especially if it's sumatriptan. Chest discomfort was also noted, and chest pain has also been reported because of the ability of these drugs to cause coronary vasospasm. That's why it is not allowed to be given in patients with coronary artery disease and in patients with angina, since this will cause an exacerbation of the chest pain. Another disadvantage is that their duration of effect is often shorter than the duration of the headache. As a result, several doses might be required, especially if the migraine is prolonged. Nalotriptan and elatriptan are contraindicated in patients with severe hepatic or renal impairment or peripheral vascular syndromes. Bromotriptan in patients with peripheral vascular diseases is also not allowed, and zolmitriptan in patients with Wolff-Parkinson-White syndrome. The branding triptans are extremely expensive, so sumatriptan should be used whenever possible since that's the molecule or the medication that is generic. Propranolol, amitriptyline, and some calcium channel blockers have also been found to be effective in the prophylaxis of migraine. Prophylaxis of migraine and not for the acute migraine attack. The anticonvulsant valproic acid as well as topiramate has also been found to have some prophylactic efficacy in migraine. So narizine, which is a calcium channel blocker, has been reported in clinical trials to effectively reduce the severity of the acute attack and to prevent recurrences. Verapamil appears to have modest efficacy as well for prophylaxis against migraine. Serotonin synthesis can be inhibited by p-chlorpheniramine, and p-chloramphetamine. However, these agents are too toxic for general use. Storage of serotonin can also be inhibited by the use of reserpine. But the sympatholytic effects of this drug and the high levels of circulating serotonin that result from release prevent its use in carcinoid. Therefore, receptor blockade is the major therapeutic approach to the condition of serotonin excess. We also have phenoxybenzamine, which is a long-lasting blocking action at 5-HT2 receptors. We also have cyproheptadine, which resembles the phenothiazine antihistaminic agents in chemical structure and has a potent H1 receptor blocking as well as serotonin blocking actions. The actions of cyproheptadine are predictable from its H1 histamine and serotonin receptor affinities. It prevents the smooth muscle effects of both amines but has no effect on the gastric secretion stimulated by histamine. It also has significant antimuscarinic effect and causes sedation. Major clinical application of cyproheptadine is in the treatment of the smooth muscle manifestation of carcinoid tumor and as well as in cold-induced urticaria. So the usual dosage is 12 to 16 milligrams per day orally in 3 or 4 divided doses. It also reduces muscle spasms following spinal cord injury. And there's anecdotal evidence that there is also efficacy as an appetite stimulant in cancer patients, but there's mixed result in the controlled trials. Ketanserin, it blocks the serotonin receptors on the smooth muscle and other tissues and has little or no reported antagonist activity at other serotonin subtypes or histamine receptors. It potently blocks vascular alpha adrenal receptors, and the drug blocks serotonin 2 receptors on platelets and antagonizes platelet aggregation promoted by serotonin. We also have ritanserin, which is another serotonin antagonist which has little or no alpha blocking action. Ondansetron is the prototypical serotonin subtype 3 antagonist, and is very important in the prevention of nausea and vomiting associated with surgery and cancer chemotherapy. And ondansetron is commonly used in prophylactic pre-surgery, medication. Considering the diverse effect attributed to serotonin and the heterogeneous nature of serotonin receptors, other selective serotonin antagonists may prove to be clinically useful. Okay, so I'll just continue na lang the remaining topic Ergot alkaloids in the next schedule, along with the next chapter, since it's already 3 o'clock. Okay. Do you have any questions? If none, then good luck at your exam. Happy CM.
Thank you, Doc.
Salamat, Doc.
Okay, thank you.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Okay, Doc.